Now it's time to go ahead, and for me, I thank you so much, and I say you goodbye, and I would like to introduce the second speaker. Od El Gilja. Od El Gilja is the actual president of EFSUM. He is from Bergen, Norway. He is a professor at University of Bergen. He published, as the other speakers, several papers, all of them very well cited, all of them very well referred. And it's now a pleasure to give him the possibility to provide to you his great experience in COS application for benign liver lesion. Please, Odd.
Great. Then I will come with great greetings from Bergen. And it's lovely to be invited to give a lecture on this occasion. And it's a very exciting occasion indeed. It's the first webinar series of EPSUM, which is now focusing on CUS. And my role is to talk about CUS of benign lesions. And ultrasound is a fantastic toolbox, as most of you know. It's not only 2D, we can use 3D and 4D ultrasound, we can use color and power Doppler, we can use pulsatile Doppler. We have now elastography methods, both containing strain imaging and shear wave. And not at least, we have contrast-enhanced ultrasound, which has developed to become clinically very important in many ways. And also we have guidance to many types of interventions using ultrasound. The agenda of this webinar lecture is to first say a few words about EPSUM's contribution in this field. Then I will follow the scheme of first talking about hemangioma, focal nodular hyperplasia, hepatic adenomas, fatty liver changes, hepatic cysts, abscesses, and finally a few words about primary sclerosing cholangitis. As many of you know, EPSUM is the organizer of this webinar, and it's an organization and federation that started way back in 1972. And now we have altogether 28 countries, and we have over 20,000 members all around Europe, and also some outside Europe. We have some very important committees, and our chairman today, Vito Contisani, is chairing the Education and Professional Standards Committee. And furthermore, we have the Publication Committee and the Safety Committee. And most importantly, these committees, they give out guidelines. And today we are focusing on the CUS guidelines. As Professor Dietrich just showed you, we have the first one appearing in 2004, and the update coming in 2008 is actually cited nearly 500 times as per today. And furthermore, the field has now been expanding to include almost 30 different clinical applications. So this is really a major force in clinical ultrasound. Let's start by just repeating one very interesting aspect. When we do ordinary scanning, so-called fundamental imaging with ultrasound, we use the fundamental frequency to look for the specific organ, and then we receive at the same frequency to make an image like this of the liver. However, when we do harmonic imaging and ultrasound contrast imaging, we receive on the second harmonic imaging in order to have greater contrast in our images. So this is a fundamental principle behind contrast agent ultrasound. And as Christoph also told you, we have three important phases of liver perfusion, actually now also a fourth that I will show you. We have the arterial phase for the first 30 seconds, we have the portal phase for the next minute, and then we have the sinusoidal phase, parenchymal phase or late phase, approximately from 2 to 4 minutes using SonarView. However, if you use another agent on the market, Sonazoid, you also have a postvascular phase lasting up to half an hour, where you can actually visualize also how the contrast agent is taken up by the Kupffer cells. The algorithm for scanning is fairly simple. The main criteria to distinguish between a benign and a malignant lesion is to look at the sinusoidal phase, the late phase. If it is hypoenhancing, you should suspect a malignant lesion. And if it is a sustained enhancement, you can suspect a benign lesion. And I will now talk about these benign lesions, starting with the hemangiomas. Typically, an hemangioma has a peripheral globular contrast pooling in the arterial phase, with a centripetal fill-in from the periphery to the center of the tumor. And many studies have now shown, also larger multi-center studies internationally, that this is a highly sensitive and specific method to diagnose hemangiomas. And we often experience in our lab that unclear findings on CT are referred to contrast-enhanced ultrasound for clarification. Typically, also seen in this patient, this tumor was not clarified on CT, but on CUS, you can clearly see this typical pattern of hemangioma, a peripheral nodular enhancement with initially no filling centrally at all. It takes time to fill up the whole tumor, usually not only 1 minute, but several minutes to be a complete filling. So the filling is very slow in hemangiomas. And you can use time intensity curves to compare the liver with the lesion and different portions of the liver of the lesion, showing clearly here that you have an initial rapid enhancement in the periphery of the tumor. This is another tumor, a roundish oval structure, hyperechoic, with no significant uptake of Doppler signals. And when we use the contrast-enhanced ultrasound, we can see that the tumor is filling in a specific pattern. Peripheral, globular enhancement, and mind you, I'm now using a high frequency and I'm using high resolution imaging, meaning that you also can see some of the liver tissue around. And this is the portal phase, and you can see how the tumor is now gradually filling in with the typical global pattern. Still not complete filling, as we also typically see has to take longer time. This is another example, a large hyperechoic tumor with no Doppler signals inside, but just in the periphery. It is also well demarcated on elastography, as you can see here, but not very hard indeed. It's in between red and bluish in hardness. And when we do a contrast-enhanced ultrasound of this large tumor, we may appreciate that the uptake also is mostly in the periphery in the start, as you can see here, with some nodular appearance. And this is also a classical case of hemangioma. This is the late phase, and this is the very late phase of this tumor with a complete filling after several minutes. One other case of a very small tumor, this time close to the kidney. You can see that the kidney is rapidly filling as usual, and then this tumor is initially quite dark centrally, but has these small nodules appearing more peripherally, classically seen in hemangioma. And in late phase, it's completely filled, typically seen in hemangiomas. This is yet another hyperechogenic tumor, and I also wanted to show you how 3D actually can extrapolate the findings. In this particular case, I had great difficulties in actually observing the nodular appearance, but in 3D, the nodularity of the tumor was quite apparent, giving a much higher sensitivity in stating that this was an hemangioma indeed. But there are some pitfalls regarding hemangiomas and contrast agents. So be aware not to use too high MI. You should go very low in MI if you suspect the lesion to be a hemangioma. The reason for that is that the flow in a hemangioma is very slow indeed, meaning that you are in danger of destroying all the bubbles if you use too high MI. Also, in the same respect, do not focus on one lesion in all phases, because then you're also destroying more bubbles and you will maybe not experience the gradual fill-in after some minutes. And in some cases, be aware that you also have to scan longer than 5 minutes in order to see the complete filling of the tumor. Also be aware that in some hemangiomas you will never see and experience a totally fill-in, because it might have some thrombosis there, and you should be aware of that. However, the typical findings I have shown you mean that you don't need to take a biopsy, you don't need to refer to another CT or MRI examination in most cases. Okay, let's move on to focal nodular hyperplasia, FNH. They typically have a centrifugal stellate branching in early arterial phase. Some of these, approximately 40%, have a spoke and wheel pattern, and the uptake is usually intense and homogeneous in early arterial phase. And with these classical findings also, we experience very high sensitivity and specificity in the diagnosis of FNH. And be aware that you can sometimes also see a scarring in portal phase in FNH. This is the Doppler finding of one lesion, and you may appreciate that you have a quite high degree of arterialization also centrally. And this is a tumor. You can clearly see the centrifugal pattern. The contrast is radiating from the center to the periphery of the tumor, and you can also see that there is a scar centrally here around the arterial phase that is very early enhancing in portal phase. And you can also see the typical scar in this case, and the changes happens very rapidly, and you need only a few seconds to see the complete filling of the tumor. And this is the late phase, the sinusoidal phase, just to demonstrate that the lesion is not washing out. Here is another case, a small tumor here. And here is the tumor, and let's see how this one is enhancing. You see a central origin, and the tumor is spreading out and enhancing long before the rest of the liver tissue. And actually, it's happened very quickly. If you look here, we have 12 seconds now where the center is enhancing, and during the next second, the tumor is completely filled in 1 or 2 seconds, which is very rapidly and much more sensitive with ultrasound contrast agents, and that's what you can find with CT or MRI. Also use the flash technique to observe how the tumor is refilling. That's one trick of the game, and in this case you can actually also see the central scarring in the middle after some time here. Classical finding of FNH. And we have a tumor of the left lobe, and from Doppler study only we can suspect that there is a central artery. So let's see if CUS can confirm this finding. Here we are. The tumor is here, and we are now in very early arterial phase, and we wait for the enhancement to appear, and we have to observe very closely, very carefully in the center of the tumor, and we can appreciate something happening here. It's radiating from the center, not the geometrical center of the tumor, but to a little left. We can appreciate that there is a filling from the center to the periphery, classically seen in FNH. And in this tumor, we also see that there is now washout of the tumor. In this case, a small tumor close to the liver capsula, we may suspect also from the Doppler that this might be an FNH. So always use the Doppler to try to identify a artery or central origin in a tumor before you give contrast agents. And here you can see very clearly the starring pattern initially of the enhancement. And also some small areas of scarring can be seen centrally. So one question for you, is this an FNH or a hemangioma? Maybe you think that this is resembling an hemangioma due to its sharp borders and the very hyper-echogenic appearance. So we use contrast-enhanced ultrasound to try if we can distinguish what this is. Look in this area here. And actually there was a central artery and there was a radiation from center to periphery of the tumor, indicating clearly that this is not an hemangioma but rather an FNH. So just to summarize the difference between FNH and others, FNH typically have a central origin, central artery sprouting into the periphery of the tumor like a firework, whereas if you compare it in HCC, for example, that tumor would typically have an peripheral origin with the artery coming in and then spreading from periphery to the center of the tumor. And Professor Piscaglia will come back to this lesion later on, so I will not go into HCC right now. Let's move instead to the liver cell adenoma that also was briefly touched upon by Professor Dietrich. This is a fairly rare neoplasm and mainly found in young women with a history of oral contraceptive use. And CUS identification of the early and homogeneous hyperechoic enhancement in the periphery of the tumor reflects the presence of subcapsular feeding arteries that we should look for. Typically, the enhancement of these lesions in the portal and late phases is comparable with that of the liver parenchyma and the surroundings, but in some cases it can also remain slightly hypoechoic in relation to the adjacent liver because there are less portal vein systems in these tumors typically, as also shown by Professor Dietrich. And we start with one lesion, and this is the kidney, and there's a lesion here. You can observe the feeding artery, you can observe the subcapsular artery, and there is a classical pattern of an peripheral to central enhancement. So then the late phase will decide whether this is a adenoma or an HCC. In this case, we found no washout, and we also did biopsy that proved that this was an hepatic adenoma. And we can again use the time intensity curve to really observe how much earlier the enhancement of the tumor is compared to the surrounding liver tissue. Here we have approximately 4 or 5 seconds difference actually in enhancement, the start of enhancement. This is another tumor. We might from the Doppler suspect also a feeding artery in this region. So let's look at the CUS examination. The tumor is here. We see a very marked artery feeding the tumor from the periphery to the center, typically as we can find in an hepatic adenoma. Very pregnant arterial feeding in this case. And here you can see it in the very early arterial phase, subcapsular artery there, and a very marked feeding artery. And this is the late phase. There is no washout, so this tumor appears to be benign. Hepatic adenomatosis is a very infrequent disorder, but in some patients we can find numerous tumors in the liver, and this is one of these patients. And you can also suspect a feeding artery here coming up. And when we use contrast-enhanced ultrasound, we can find that some of the tumors are actually also interlinked with a common artery. In this case, 2 tumors are easily seen in these patients with hepatic adenomatosis. So just to repeat for you the various forms of FNH, Pathologists have now divided these lesions into a mutated one and in those tumors that do not mutate. And Christoph touched upon these, also the HNF1 alpha inactivated. These are predominantly in fatty livers, and they are not supposed to do a malignant transformation. However, the beta-catenin activated tumors, they might potentially convert to malignant states, so be careful about these. Then you have the non-mutated ones, the inflammatory and the non-inflammatory, and the inflammatory ones, they have an origin from the previous classification as being telangiectatic FNH. So this is, of course, the distribution of adenomas. Sorry, the heading is not correct here. So let's change subject. Let's move to something that might be dangerous. What about fatty liver lesions? In many aspects, that might be not an easy case to solve. And sometimes we observe findings like this. Small lesions, hypoechogenic, could be suspected of being metastasis. And these are becoming more and more frequent in Europe these days as we grow fatter and fatter, unfortunately. And we can use contrast-enhanced ultrasound easily and rapidly to rule out whether these are benign or malignant lesions. When they behave like the rest of the tissue of the liver, like in this case, both in portal phase and in late phase, we can conclude that these are benign fatty lesions. But particularly in the patients with a malignant history and a previous malignant disease, we are very urged to do a rapid clearing of these lesions. And this was one hypoechogenic lesion, and we can see that this is not suspicious in late phase of the CUS examination, indicating that this is a benign lesion, and indeed it was. Some fatty lesions are more complex, like this, large area that are hypoechogenic, but also in this case we could by CUS conclude clearly that this was benign lesions. Here also seen in late phase, there is no washout at all, and also in this case there was done a biopsy that showed only fatty tissue in this case. And this is a case referred from a general practitioner who did ultrasound himself, and he wondered what kind of lesions are these. These were quite strange to him. And of course we did contrast-enhanced ultrasound, and in late phase we can see that the appearance is normal compared to the rest of the liver tissue. There is no washout, and we could conclude with benign fatty changes. What about cystic lesions? Cystic lesions more and more actually are referred from the CT lab, particularly in small cysts. CT has difficulties in establishing and characterizing the lesions adequately. And I get more and more of these lesions, and particularly those who seem to have content is important to clarify. And you can see that this content is only dead material, no danger at all, no metastasis in this case. This was actually a 50-year-old man that was referred from after a CT examination, where the radiologist was really scaring him because he told him that you only have a few months left to live, because he was pretty sure that what he diagnosed on the CT was metastasis. However, this is the tumor, the very suspicious tumor. You can see he has a cyst close to it, and he has other cysts of the liver. So he came all the way from another part of the country to make this examination, and you can clearly see that this suspicious lesion upon CT was actually a benign cyst, no danger at all. So he could walk up to the ultrasound room with a straight back and a new hope for his life. In abscesses, we have also classical findings that you should be aware of. Usually there are some debris into a large or small lesion of the liver, and we use contrast to observe if there is a classical pattern of abscesses. And the classical pattern is that you should have no central enhancement but peripheral enhancement where the active inflammation is taking place, and the zone of inflammation is highly active. So typically, as seen in this case, and we also confirm that with the late phase scanning, and in this patient it was culture positive for Staphylococcus aureus. So I would like to draw to a conclusion soon. When you are in doubt as a doctor, use ultrasound to sound it out. And this was also another patient referred from the CT lab. The patient had a suspect malignant lesion in the gastric cardia found by endoscopy, and the CT was not conclusive, but they found numerous lesions of the liver, and the patient was referred for clarification with contrast-enhanced ultrasound. And this is the B mode appearance, and some of the lesions were like this, and we shall now inject to see what happens. There's one lesion there, there is one lesion here, and let's look in the arterial phase how that appears. You may appreciate that there is an enhancing lesion there, and there is an enhancing lesion there, not acting like a cyst. However, if you look around in the liver, we might find other lesions that are typical for cysts, but in late phase, some of these were classical washout lesions. So this patient actually had 2 different lesions, many cysts, but 2 lesions that was very suspect for metastasis, and that was proved also to be the truth. Finally, a few words about primary sclerosing cholangitis, which is a disease, a chronic liver disease, often seen in patients with ulcerative colitis and Crohn's disease, which leads to an bile duct inflammation and progressive fibrosis of the liver. And typically, you may see dilated bile ducts like this and like here. And in some patients where the disease is progressing, you may also experience intraductal growth. And the question to you as doctor is, of course, is this just inflammation or is it malignant conversion as well? And this is the area of interest, and we should now visualize how contrast-enhanced ultrasound is characterizing this lesion and this growth inside the bile duct. And look here, there is a hypervascular phase inside the growth of the bile duct, arising long before the rest of the liver tissue, indicating that there is significant disease activity in this region. And also using the time intensity curve, we can clearly observe that the rise in enhancement occurs long before inside the bile duct compared to outside the bile duct. And in this case, it was inflammatory changes, no malignancy in this case. So to sum up, if we look at the total schedule of focal liver lesions, it's important to distinguish between benign and malignant, of course. And the different benign lesions we have now gone through, we can actually characterize and distinguish hemangiomas from focal nodular hyperplasia from adenomas by looking carefully at all the 3 phases of liver enhancement. And just to remind you also that CUS is a fantastic tool. It outperforms CT and MRI often, in many cases, due to its high temporal resolution and very good spatial resolution. And using second-generation ultrasound, the method is really established now as an important clinical tool in many cases. It's easy to apply in a clinical setting, and it does not prolong the examination time with more than 5 to 10 minutes usually. Attention to mechanical index is crucial in order to characterize properly the tumors, and benign lesions of the liver can be characterized and differentiated to a large extent. And both detection and characterization of FLLs are significantly improved by adding CUS. So thanks also to my ultrasound group in Bergen, who has contributed largely to the studies we do. And finally, also let me remind you about our website, www.afsum.org, where you can find a lot of teaching material. You can find courses on CUS. You can find seminars on CUS that have been recorded previously. for you to enjoy and to learn more about contrast-enhanced ultrasound. And finally, let me also remind you about our next big congress, the Eurosound Congress in Leipzig next year, end of October. You are most welcome to join us there and to learn more about contrast-enhanced ultrasound. Thank you very much for your attention, and I'm happy to also receive questions.
Thank you so much, Odd, for being in time, for providing us this very nice, comprehensive overview of the main features of benign liver lesions. Now there are some questions for you. The first one comes from Maya Rasina. She's asking to you, when you deal with benign regenerative nodules, or what are referred to be benign regenerative nodule after chemotherapy, for how long do you suggest to follow those kind of patients?
So I guess this is a patient with cirrhosis. That means that we do follow them all the way to either death or transplantation usually. So typically we will follow them actually for many years. I guess the nodules and the characterization of nodules related to cirrhosis and HSC will be dealt with in the next lecture by Fabio Pescaglia.
Yeah, but there are also some benign lesions also for chemotherapy, for other treatment, for instance, breast or colon cancer. And sometimes liver could develop some benign regenerative nodules. And of course, yes, we suggest to follow up also by using MRI in addition to CUS. Second question is from Lorenzo Mulazzani. He's asking you again also, I asked to Christoph, but he asked to you again, what is, in your opinion, the role of time intensity curve in your daily life, also for benign liver lesions?
The time intensity curve is mainly an add-on in the clinical daily routine. I do not always use it, but if I want to really compare different parts of a tumor or different parts of tumor compared to surrounding liver or to even a kidney, I use it to illustrate and actually also look very carefully how the different portions and segments of the liver actually enhance, particularly in relation to the actual focal liver lesion.
I totally agree with you. Third question, the last one. When you deal with a large hemangioma, which does not fill in completely at 4 or 5 minutes, for how long do you suggest to check and to follow up? Or do you suggest to use a different technique?
Yes, I think the bottom line here is if you are still in doubt, not able to fully sound it out, you should supply with other imaging modalities. And indeed, large hemangiomas can also often be difficult due to thrombosis, some internal bleedings and so forth. So they can be a little bit tricky. So in a very few cases, you take a biopsy, but mostly you will refer them to MRI with an hemangioma regimen for further characterization.